as with a FIT test or Cologuard, and then colonoscopy. Breast cancer screening has a grade B, women aged 50 to 74 years old, biennial screening mammography. And there are several different organizations that have guidelines on this, but starting screening at age 40 or 50, depending on which guideline you're following. Lung cancer screening, adults aged 50 to 80 years old with any history of smoking. That one was updated recently, has a grade B. And annual low-dose CT scan. And again, this part, the 20-year PAC history, is the part that's been updated to basically just anyone with a significant tobacco use history. And then prostate cancer screening has a grade C, and that's men aged 55 to 69 years old. And then that's with the PSA blood tests. So in order for a cancer screening test to be recommended for a population scale, it has to meet certain criteria, and that's part of what we're going to get into in the next slides. So another thing to bring up when talking about cancer screenings is just the suboptimal use of these screening tests in the United States specifically. So 78.5% of women aged 50 to 74 are not up to date with mammography. 17% of women aged 21 to 65 are not up to date with their PAPs. 38% of adults aged 50 to 75 are not up to date with their colon cancer screenings. And 96% of adults who qualify for that low-dose CT scan have not had their lung cancer screening. Lots of things go into this, but there are unmet needs in cancer screenings. So there may be lack of available screening testing for the multiple cancer types, inadequate awareness of and access to screening in certain populations and in certain locations, lack of knowledge regarding specific recommendations for screening, misconceptions about the tests themselves, low patient engagement, disparities in screening practices across different communities and populations. So disparities are present all across our healthcare system, but including cancer screenings. So these are influenced by numerous factors that include geographic location, income, education, national origin, and race, ethnicity. So for breast cancer screening, one of the examples is a study that showed in 2018, only 63% of women with less than a high school education were up to date with breast cancer screening, compared to 80.4% of women with a college degree. And then, down at the bottom, prostate cancer, again in 2018, only 8.9% of uninsured men age 65 and above were up to date with prostate cancer screening, compared to 34.4% of those who had any private insurance. So there's disparities, and then even with the people who are not in these groups, it's still not even close to 100% or anywhere where we would like it to be. And then just to bring in the piece with the nurse practitioners, we as nurse practitioners are uniquely well positioned to promote improvements in cancer screening, as we are oftentimes the primary point of contact for healthcare in rural and underserved areas. Among other areas, we have an expanding role in primary care and advanced scale in patient education and engagement, both of which are associated with greater adherence to cancer screening recommendations. And we are also positioned to advocate for and support effective screening policies. So with that background, that's kind of where we've been. And with these blood-based multi-cancer screening tests for the early detection of cancer, to me, that's where we're going and where things are probably moving. So a blood-based multi-cancer test is a minimally invasive test with low procedural risk. It detects cancer cells or genetic material in the blood from primary tumors. This is going to find aberrations that are evident during early tumorigenesis. There's signals that are there for analysis, and tissue-specific alterations, which can help to identify the tissue of origin of where those cells are located in the body. This type of test does not replace a biopsy diagnosis, a tissue-based diagnosis, but it does provide sampling for molecular characterization of tumors. And the other amazing thing about it is it detects cancers that we don't currently have screening tests for. Lots of cancers that we don't have screening tests for currently. Anything other than that 5 that we just talked about. And comparing the liquid biopsy, which a liquid biopsy is just, it's a blood test. That's how the test is run, versus a tissue biopsy, is invasive, sometimes requiring surgery, anesthesia, all of that can take a long time. Whereas the liquid biopsy, like I said, just a blood test, so it's shorter. It does have a higher sensitivity because that's collecting cells from the entire body, whereas obviously with a biopsy, you're going into one very specific location and could miss cells if it's not right there where you're checking. Lower cost with a liquid biopsy compared to the higher cost with a tissue biopsy. Obviously if, surgery is involved and anesthesia and a whole team of people can be a lot more expensive to do that. They're both clinically validated, but the tissue biopsy does allow you to do histological evaluation, staging, and that type of thing, where the liquid biopsy does not. Okay, so when getting into some of the details about the multi-cancer early detection testing, I just wanted to review some of these terms. So sensitivity, specificity, and positive and negative predictive values. You might remember these from stats. So sensitivity is the ability to correctly identify people with the disease. Specificity is the ability to correctly identify people without the disease. The positive predictive value is the probability of having cancer giving a positive test. The negative predictive value is the probability of not having cancer given a negative test. And then the number needed to screen is the number of individuals needed to screen to detect one true positive. A couple more terms. Prevalence is defined as the proportion of the population with a specific trait in a given time period. And the PPV is determined by specificity and prevalence. So given a positive test, what is the probability that that individual actually has cancer in this case? So the aggregate prevalence rates of all cancers, let's say we're doing 50 cancers versus a single organ screening. So one test to identify one cancer versus, one test to identify 50 cancers, you can have a much higher positive predictive value of that test. So this is just for example. Among GI cancers, currently only colorectal cancer is considered prevalent enough for population screening with the, the Cologuard, FIT test, colonoscopy, that type of thing. So for colorectal cancer, you need to screen 167 individuals to find one positive. But if we were to broaden that to a less common cancer like pancreatic, the number needed to screen is 500. For esophageal, it's 1,000. So you can see how that changes the types of tests that we're recommending for population screening. But then if you say all GI cancers, we're going to put all those in one bucket, the number needed to screen goes down to 83. And if you could test for all the cancers, then you only need to screen 33 people to find one positive. And that is aggregate prevalence kind of explained. Okay, so the science underlying cell-free DNA-based multi-cancer early detection tests. So cell-free DNA is a term I think we'll all be hearing about a lot more. Cell-free DNA are particles that can be found in the bloodstream that show kind of what's been going on in the body. So it includes when a cell undergoes apoptosis, necrosis, there's particles that will be released that you can look at and analyze through the blood, and then also things that these cells secrete. So apoptotic bodies, point mutations, copy number alterations, rearrangement, methylation changes, exosomal DNA. Those are all things that we can identify as not the cell-free pieces of the DNA. So composition of cell-free DNA in patients with cancer. So starting on the left, our patient has no cancer, so they have a normal, healthy baseline. Their cell-free DNA mostly has hematopoietic origins. Can't say that word today. So it's normal blood cell-free DNA. If this patient was to have lung cancer, then those cell-free DNA pieces are going to show the normal blood cell-free DNA and also the lung cancer cell-free DNA. And let's say that this cancer that started in the lungs is now metastasized to the brain. You will have the cell-free DNA of the normal brain and the normal lung. Then you'll have the primary lung cancer cell-free DNA and the metastatic lung cancer cell-free DNA. And that can all be identified and linked back to where it came from. So the way this works in practice is a liquid biopsy, which is a blood test, is taken. That is sent to the lab to undergo cell-free DNA enrichment sequencing that will be able to detect the cancer and also the tissue of origin, which then will come back to the provider and the patient. And then there's kind of the team-based approach, including, whatever type of imaging, blood work, biopsy, pathology, whatever specialists are need to get involved. And then at that point, whatever testing happens, you get the confirmed diagnosis. So a positive cell-free DNA test is not a diagnosis. It's simply a signal on where to go next to achieve that diagnosis. So there are multiple ways of doing this. There is somatic mutation analysis, DNA methylation profiling, and fragmentation approach. There's been studies done on all these ways of detecting cancer through cell-free DNA. And we'll talk a little bit more about that as we go along. DNA methylation profiling in early cancer detection. So the rationale for use. So the DNA methylation in normal cells, the repetitive sequences are methylated, where the tumor suppressor gene promoters are unmethylated and active. Those lead to the active tumor suppression. In cancer cells, the repetitive sequences become unmethylated and active. So they have genomic instability, and that promotes the aggressiveness and escape. So it's just how they are finding this in the blood. So this change, though, it does occur early in tumor genesis, so very, very early stages of cancer. And like I said, it's cancer specific and tissue specific. So blood-based multi-cancer early detection testing, available options, and clinical trial evidence. All right, so we'll get into some of these studies. The DNA methylation-based tests that have been done. So there are a lot of these tests that are currently in development. Right now, Gallery is the only commercially available multi-cancer early detection test. It is not currently FDA approved, but it can still be tested under a CLIA waiver. So a provider can order it, send it off to the lab, and can be used currently, not just in research. So the Gallery test, it looks for over 50 types of cancer. And this is basically just talking about how they just determined that the methylation would be the way to do it. So they developed this target methylation assay combined with a machine learning classifier for detecting and discrimination tissue of origin in more than 50 cancer types using cell-free DNA. They found that it has a 54% sensitivity and a 99.3% specificity obtained in the validation set and 93% accuracy for tissue of origin prediction. So that's one thing just to note is these tests are highly specific, so a very low rate of false negatives. but moderately sensitive, so a higher rate of false positive. So that's just something to keep in mind as these new tests come out. That's something to just kind of watch for, is that sensitivity. If we're able to increase that, I think these tests will continue to be used more widely. And then in addition to the Gallery, there is Panseer, which is Singular Genomics. They have a test that checks for lung, colorectal, gastric, liver, and esophageal cancers. And then they did have a higher sensitivity with that, and a little bit lower specificity. And they did do some studies, though, that showed that the cancer detected by this test can be found up to 4 years before conventional diagnosis. And we'll get into that a little bit more, too. And then there's CancerSeq, which is Exact Sciences. They have a test that looks for lung, breast, colorectal, pancreas, gastric, liver, esophageal, and ovarian. And then, as you can see there, it's 62% sensitive, 99% specific, and also 63% accurate for the tissue of origin. And this is just a bit of an overview of all the clinical trials. And this is not even all the clinical trials. This is just a selection of them. But there's more trials going on right now as well. So Gallery has done several of these. The CCGA had over 15,000 participants, male and female, and it demonstrated the feasibility of detecting cancer and predicting tissue of origin with minimal false positives. The Pathfinder had 6,621 males and females, and they were looking at how this test actually does in real clinical practice from start to finish, from the beginning of the test to the resolution, diagnostic resolution of cancer. Strive had almost 100,000 female participants. They confirmed performance in individuals with no known active cancer diagnosis. The Summit study, 25,000 people. I mean, you can see these studies, there's a lot of them. And Gallery's had the largest amount of studies, but the Detect A CancerSeq one, we'll talk more about that as well. All right, so the Circulating Cell-Free Genome Atlas was one of the first tests. And basically this is when they decided to do the whole genome methylation process for analyzing the cell-free DNA. So this is kind of one of those original studies. That's how they decided that was the method to use. So the clinical limit of detection is a useful benchmark to assess cell-free DNA-based test performance. That was the findings of the study. And the CTAF accounts for cell-free DNA cancer signals variation across cancer types and stages, and that they just found that the methylation was the most promising genomic factor for cancer signal detection. And so that informed the development of the test that we currently are using, the Gallery testing, and the others as well. So the Pathfinder study, so this one was designed to include individuals 50 or older, some of them with cancer risk factors and some with no risk factors. And then it included anyone who had any clinical suspicion or a diagnosis of cancer or treatment for cancer within 3 years of enrollment. So anyone who had had cancer that was in remission for longer than 3 years or not on treatment for longer than 3 years, those people could be included, but no one who had been recent. So they designed the study to be done in clinical practice. So this followed through from when the test was ordered. The patients underwent a questionnaire, the blood was drawn and shipped, it was received, analyzed, the test report was generated. Then that test came back to the providers with either the signal detected or not detected. And if it was detected, that they followed it all the way through to the diagnostic resolution, whether that was one of those false positives that ended up not having cancer, or if they ended up having cancer. And then if they did have cancer, they watched them for 12 months after. And then also with the people who got a negative test, then they assessed them at 12 months later as well. So they found in this study that the time to achieve diagnostic resolution was 79 days. So that means from that first interaction of the patient agreeing to join the study to either having the positive, the cancer ruled in or ruled out, was about 3 months. And my clinic here in Utah did participate in this study. And I think that it's worthy to note that this was right when the COVID pandemic began. So I do think that that 79 days got drawn out just a little bit with all the chaos that was going on at the time. We had this whole process going and getting people enrolled. And then once the pandemic began, they basically had to change kind of the process up midway through and adjust it a little bit to keep people safe. So, but regardless, we did get good results with this, and they were able to see how it worked in real life in primary care settings. So part of the study was it was this survey that they gave the patients. So that last column, the psychological impact of the test, they found that 97.1% of people felt highly satisfied with their results. And that was even 82.3% of people who got a false positive still reported feeling highly satisfied. 83% felt very or extremely confident that the test was beneficial, and 95% of people were likely or very likely to follow recommended screenings. There was no safety events. And then we did kind of review this. It came out with, about a 50% positive predictive value, a very high negative predictive value, 99.1% specificity. 189 people needed to screen to detect one cancer. And then the tissue of origin, 96.3% accurate as well. So the Simplify study, the symptomatic patients referred from primary care, 6,228 participants were provided consent and enrolled in the study. Some were excluded. And as you go down here, there were 374 that were diagnosed with cancer through the standard referral pathway. They did get almost 370 participants who did get the cancer diagnosis in this study. So they had more signal detected patients in this trial, a little bit higher positive predictive value, slightly lower negative predictive value, but really similar. And then the 85.2% accuracy for the tissue of origin. And they found that this was the study where they looked at finding these cancers at these early stages compared to people who just underwent the standard screening guidelines. So that was interesting. So the Detect A study was one that used the PET scans. So this was all women, almost 10,000 women without a history of cancer that were enrolled in the Detect A that's done by CancerSeek. And they coupled the PET scan with the multi-cancer early detection testing to identify cancers, including those not detected by the standard of care screening, which majority were localized or regional. So they found some things that will kind of go into the next generations of the test. So additional biomarkers, new analytic methods, algorithms that are currently being incorporated in the development of the next generation of the test. So the clinical outcomes, they did follow that as well. And then they found that the multi-cancer early detection testing detected cancers earlier in patients who, when treated subsequently with conventional methods, achieved long-term survival. And then so far, half of the patients that were detected through the multi-cancer early detection test have remained cancer-free. That was 4 years after the initial test. And this kind of just shows similar, stats as far as following them all the way out to the 4 years. All right, so barriers with cancer screening. So we still have all the barriers that we talked about in the beginning to our standard of care cancer screenings. And those are mostly all the same with this test, but there are, some pros and cons that come with this type of cancer screening test. So we'll talk about that. I think that the main thing with the multi-cancer screening test is having that high false positive rate can involve a lot of subsequent downstream. I mean, there's possible high, there's false positive rates with any cancer screening. We know that there's a chance of that with the colon cancer screening and the breast cancer screening. So that's not really anything new. It's just slightly higher with this type of test. But regardless, evidence-based interventions to improve cancer screenings. So we have patient-oriented and provider-oriented interventions. Some ideas are patient reminders, so scheduling screenings by contacting patients or talking to them during visits, sending appointment and test reminders, providing support to help overcome barriers and prepare for the tests. So really educating people on prep and things like that. Reducing paperwork, helping with scheduling, offering screenings at lots more locations. Expanded clinic and screening hours, providing transportation, childcare, that type of thing. Using videos, brochures, newsletters, one-on-one or group education to motivate screening, using vouchers, reimbursements, or reduced copays to remove economic barriers. And then on the provider side of things, using our EHR or stickers or notations on medical charts or EHRs to send alerts, listing patients who are due for cancer screenings daily. Tracking screening for clinics, individual providers, reviewing the clinic policies and practices, telling providers how many of their patients get screened and receive follow-up care. Just kind of tracking these things a little closer, making it a priority in addition to everything else we do as primary care providers. So let's get into a case study. Okay, Jonathan is a 52-year-old Black man with a family history of prostate cancer who presents for routine primary care visit. He has recently come across information about multi-cancer early detection tests and requests further information. Specifically, he would like to know if it might be a good option for him. So what type of education is needed to help guide the evaluation of the testing options, implications of the test results, positive or negative, information on the likelihood of getting a false positive or a false negative, test sensitivity and specificity, rationale for how the test works. Yeah, so they're all kind of important, but implications of the test results, positive or negative, I'd say that's going to be important before the test and after to remind patients that a positive result is not a cancer diagnosis is really important to make sure people understand. Which of the following most strongly influences whether or not you would offer testing to a patient like Jonathan? A family history of cancer, patient having a personal history of cancer, whether the patient is up to date on screenings, the patient's ability to pay for the test. Yeah, so currently the test is indicated for people who have risk factors for cancer, including family history. And then if he had a recent history of cancer, that would obviously exclude him for doing it. And then the ability to pay for the test. It is an expensive test. We haven't talked about that yet, but since it's not FDA approved, it doesn't have great insurance coverage. So that's an important thing to discuss as well. So potential challenges and benefits of multi-cancer early detection testing. Positives, it detects more cancer types, it's non-invasive, it has rapid results, it's easy to use in primary care. Negative, cost and access constraints and equipping patients to evaluate benefits and harms. So the cost and access constraints are a big factor. I mean, it's hundreds of dollars to do this test. There is minimal insurance coverage. Where I practice here in Utah, we do have an insurance that does cover for very specific individuals who have a specific insurance plan and meet the different criteria, but a lot of people don't have that insurance. So that's something to consider with this. And then again, just emphasizing the high rate of false positives, and that these people may end up undergoing more downstream testing that has potential harm with eventual resolution of not having cancer. Best practices for multi-cancer early detection implementation, effective discussions with patients. So as it stands, eligible populations for existing tests, patients ages 50 and older at elevated cancer risk. It's not recommended for individuals who are pregnant, age 21 years or younger, or undergoing active cancer treatment. So really just anything that, I mean, people that it hasn't been tested on, but people who could have any abnormal cells going on in their blood that would kind of change the findings or confuse the analysis. And then importance of interpretation of results as one tool in a set of therapeutic screening options. And it's very important to emphasize that the standard of care testing, mammography, colonoscopy, PSA, PAPS, those are all still very important. This does not replace any of the standard of care tests. So this is a list of questions from the Cancer Patient Advisory Board when they were asked what would patients need to know before considering multi-cancer early detection testing. And this is a pretty extensive list. So it's things about, the cost and the access, how often can someone use it? What do companies do with the data that's obtained from this test? How could these test results be used in other settings? Can it detect precancer? Can it check for remission of cancer? Can it tell, if the cancer is aggressive or, staging it? Those are all questions that people are going to be asking. So they're good to kind of keep in mind as we're thinking about talking to our patients and anticipating what kind of questions they might have or what questions that they should have. So currently, to do this test without insurance coverage, and again, this is just locally here for me, it might be a little different in different areas of the country, but the test is $949 and you can go through the Gallery website to do it. And how that, you would go to the Gallery, you get the form, you fill it out, you complete the blood draw, and then once the test is done, you'll receive the results, typically within 10 days of the reception of the blood specimen, and the results read either cancer signal detected with signal origin or cancer signal not detected. And so if it's detected, that's when you go into the diagnostic testing. So when we have done the tests, we've had a few positives at my clinic here. And there have been some new cancers that have been discovered. There was also a patient who had it run. He had a slightly high PSA, but not to the point where we were referring him yet. But then this test came back positive for prostate being the tissue of origin. And so we kind of, referred him to urology, and he previously was a little hesitant to go. The PSA was only mildly elevated, so this was a good motivation for him to go in. We had another one that it was a blood-based cancer, so got them referred to hematology. And, it wasn't an aggressive cancer or anything like that. It's just one that they're going to monitor, but at least put it on the patient's radar. I also had a patient who had a normal mammogram that year, and hers came back positive for breast cancer. And, this is about 6 months, so about halfway in between when she would have done her next mammogram, was able to get the diagnosis of breast cancer, a lot sooner than if she had waited for that next mammogram, if it would have even caught it at that point or the next year after that. So there are certain cases in which it can really speed things along and get people started on treatment a lot sooner. Next patient case. Marlena is a 58-year-old white woman with a family history of ovarian cancer. She has recently undergone multi-cancer early detection testing. The results indicate a positive signal for cancer, and the cell-free DNA fragmentation suggests a pancreatic tissue of origin. So what is the next step once Marlena's test results have been received? Explaining the meaning of the cancer signal detection, ordering a blood workup, ordering a biopsy, or repeating the multi-cancer early detection test to ensure results. Yeah, I do think that even though we've explained the meaning of the cancer signal detection, this is a great time to reinforce this is not a diagnosis. There's a lot more workup that needs to be done. Depending on the cancer type, blood tests, referrals, imaging, eventually probably do getting a biopsy. But repeating the multi-cancer test, that's the only one that's not what we would do at this point. So what additional testing is needed to diagnose Marlena? Blood tests, imaging, tissue biopsy, or all of the above. We would be doing all of those things, or we would be starting some of those things and referring to have the rest of those done. How would you sequence Marlena's follow-up evaluation referrals? So blood work, imaging, biopsy, imaging, blood work, biopsy, or just straight to biopsy and then doing imaging and blood work? So I personally would be going the blood work, imaging, biopsy route, least invasive to most invasive, but that might depend a little bit on the type of cancer, but generally that's a good option. So when discussing the multi-cancer early detection testing with your patients, again, emphasizing the meaning of the signal detection, potential for false positive or false negative results, keeping in mind the psychosocial impact of screening is relatively low overall and short-lived, even with false positive results. And again, I think just telling people that up front and just being really clear about that right off the bat kind of can help just anticipate some of that psychosocial impact. And obviously those at high cancer risk, I'm sure we've all, either evaluated these patients or maybe we are these patients. Those at high cancer risk tend to experience more symptoms of anxiety. So discussing more intensive screenings for patients with a positive signal, that also is kind of wise to do beforehand, just kind of taking patients down that pathway, before you're actually there of if you have a positive signal for this type of cancer, these are the type of tests that we would then order. These are the type of biopsies that might entail, and making sure people are just very informed with their consent before ever starting this screening test. So what might be the most challenging aspect of supporting a patient after a positive screening test result? Ensuring they follow up with diagnostic referrals, helping them navigate cost barriers to obtaining appropriate diagnosis, helping them manage the long-term negative psychosocial impact. Yeah, and I think some of this depends on the patient themselves. At least with my patients, when you know your patient, you know if they're the one who is more likely to have a negative psychological impact. You know if they're the one you're going to worry about getting those referrals done. But kind of across the board, I mean, again, depending on insurance coverage, helping them navigate the cost barriers to obtain an appropriate diagnosis. As I have mentioned, the high false positive rate, how will insurances cover this additional testing, especially if it ends up that the patient does not have cancer? Does that mean that they're going to cover that PET scan or those tests that wouldn't have been done otherwise? So that's kind of something that I think we'll learn a little bit more as time goes on, but definitely something to keep in mind as we are educating our patients on this. Barriers to seeking further detection and testing after a positive screening results. Again, not just the multi-cancer early detection test. This is all positive cancer screening test results. So this is positive mammograms, colonoscopies, all of the things. So psychological barriers, patients feeling like they're in shock, not knowing if they believe the results, not believing it because they don't have symptoms, not knowing where to go or understanding next steps or where to go, fear, just in general, not believing traditional treatment like chemotherapy is safe, not understanding how serious it could be. And then on the other side of that, we have the access barriers, the practical barriers. Medical centers are far away. They don't have transportation or childcare. They can't take time off work or don't have a caregiver or someone to take care of them, and obviously cost. So in summary, early diagnosis is critical for achieving improved treatment outcomes and survival in patients with cancer. Blood-based biopsies can promote earlier diagnosis by enabling simultaneous detection of biomarkers of multiple cancers early on, as well as information on cancer type and tissue of origin. Multiple multi-cancer early detection tests have been and are being developed and have shown promise in clinical trial investigations. Although no multi-cancer early detection tests are currently FDA approved, the Gallery test has recently been made available via a CLIA approval waiver. Multi-cancer early detection tests have the potential for routine application in primary care and may help reduce barriers to effective population scale cancer screening. And it looks like we're doing questions and answers now. Oh, I guess we'll do that maybe at the end. Is that right?
Yeah, we can do the post-test.
Okay, we'll do the post-test first.
Yeah, the post-test is first, so that's going to be
Great.
your first question and answer.
Okay, excellent.
Sorry.
That's okay, my bad. Okay, so which biologic entity do currently available multi-cancer early detection tests detect? Circulating cells with DNA abnormalities, circulating DNA released by cancer cells, circulating miRNA released by cancer cells, circulating proteins released by cancer cells. Right, so the most specific answer would be the DNA released by cancer cells. What is the mechanism of detection of currently available multi-cancer early detection tests? Somatic mutation analysis, genome-wide fragmentation analysis, or DNA methylation analysis? Correct. That DNA methylation analysis is what the current tests are using. So Martina is a 50-year-old woman with a family history of endometrial cancer who has come in for her annual visit. Should you raise the possibility of undergoing multi-cancer early detection testing? A, no, multi-cancer early detection tests are indicated as a screening tool for patients with a personal history of cancer. B, not at this time. Multi-cancer early detection tests are indicated as a screening tool for patients over 60 with an elevated cancer risk. Or C, yes, multi-cancer early detection tests are indicated as a screening tool for patients over 50 with an elevated cancer risk. That is the correct answer, C. So what do patients need to know before considering multi-cancer early detection testing? If positive, test results are interpreted in conjunction with traditional screening methods. The test can detect the presence of cancer, but not the tissue of origin, or the discussion regarding pain management that may be needed prior to the test. It can detect the tissue of origin as well as the presence of cancer, and it's just a simple blood draw, so no pain management is needed. And then what tools do you currently use to improve cancer screening rates among your patients? Do you do scheduling screenings by phone or during visits, sending appointment and test reminders, providing informational support to help patients prepare for tests, using videos, brochures, or newsletters, providing group education or one-on-one education to motivate screening, or using your EHR or medical charts to set alerts for providers? Excellent. Lots of good options there. Okay, thank you. So now I believe we'll be going into the Q&A part.
Yes. All right. Thank you so much, Lee. Always great information.
Yeah.
All right, let me get to our questions. So just a couple of questions for you. What is the most common question or concern that comes up when discussing the use of MCED testing with your patients?
Well, I think I emphasized it in the presentation, but I just think that the subsequent testing that patients might have to undergo, given the high false positive rate, is really the main thing. I mean, it is an amazing test and great that we can check for so many types of cancer, but just really emphasizing 1 out of every 2 is a false positive. And everything that entails is, I think, key.
That's helpful. And this kind of leads into the next question. What type of psychological support is available, or what do you recommend for patients undergoing this MCED testing, or any resources?
Yeah, I mean, I think that depends on the individual. And at least with me, I think you kind of know which patients, what type of anxieties they might have going into it. I don't know that there's any specific resources for this, but just in general, you know, the talk therapists and mental health coordinators, that type of thing, if that's available in your clinic, or really just a really thorough assessment and explanation with the provider, I think can go a long way, and close follow-up as well.
And then talk just a little bit about cash price versus insurance and Medicare coverage.
Yeah, so like I mentioned, I'm just speaking from my experience here, but I've seen Medicaid and private insurance coverage. And when that has happened, I believe it is fully covered 100% for this initial test. As far as subsequent testing, I can't really speak to that 100%. But again, in those several cases that I saw, patients did tell me that it was covered, the subsequent testing, just like, the prostate biopsy in that case was just the same covered as if it would have been referred for a high PSA, that type of thing. So, and then the cash price, we did discuss that as well. It's about $1,000 for the test.
And walk me through in your office, if you identify someone who's an appropriate candidate for the testing, do you do that in your office? Do you send them elsewhere? What does it look like?
Yeah. So, I mean, in our clinic specifically, it's just the same if you're doing all their other routine labs. So if they're due for, their chemistry and their cholesterol panel, they just draw the blood at the exact same time. So we do that in the patient rooms. I don't know if other clinics have it set up to go to a lab, but it would just be like any other blood test that you would order.
Okay. I don't know if you know, but from your experience, how do oncologists view these tests? Useful, not encouraged? Are more people recommending it? Kind of what's the thought since it's kind of a one to...
Yeah, I think initially there was more resistance, especially just making sure there are, this is going to open up a lot more patients being referred to oncology in general. So just making sure that there are those available providers to refer people to this. I think that's the main concern I've heard expressed, is making sure there are availability with those specialties. But I've heard encouraging things from the oncologists, and they're aware of these tests, and they're figuring out the best way to approach this as well. If there's initial testing they'd rather have primary care providers do, and just communicating what those tests might be before sending the referral versus who they want sent to them to have the full workup done initially. So,
and then going back to kind of the paying for the test, do you send your patients to their insurance? Do you have them go check if it's going to be covered? Do you guys in your office check coverage? Kind of how does that work?
Yeah, we were just told which insurances cover it right off the bat.
Okay.
It's just one here.
Well, that's helpful.
So that's pretty simple. But and as far as I know, other ones just aren't covering it. But if I was to ever talk to a patient, I would probably just tell them the cash price and then say, you could always check with your insurance to see if it's covered. But if not, this is what it will cost. So
Gotcha. Yeah. Perfect. And then somebody made the recommendation. It's really a good recommendation in talking about psychological support and what's available when they have testing. They mentioned, referring to PsycNP to deal with kind of the anxiety and the psychosocial issues, and recommending kind of close follow-up.
Yeah, for sure.
Yeah. And then when you're ordering in the EMR, what diagnosis code?
So there is a specific diagnosis code that is for cancer screening. It's just a general code, and it says right there on the form when they send it to you to fill out. So it gives you specific details on how to do that. Perfect.
All right. Any last thoughts or anything?
No. Happy to be here. Thanks for having me. And if there's any additional questions, feel free to send them my way. So
great. Thank you so much, Lee. Again, great information, so helpful, and really kind of puts a new something in your arsenal for cancer
and something
screening.
Just to consider moving forward that we're going to be seeing more of. So
I think we are. Yeah. Absolutely. Great.
Thank you so much.
Lee. Bye. All right. One more presenter, and then you guys are going to have the rest of your day. But with this lady has spoken for us before and needs no introduction. She really is all things cardiovascular when it comes to nurse practitioners and cardiovascular work. Kathleen Byrne is a cardiovascular nurse practitioner, certified. She practices in Baltimore, Maryland at the Johns Hopkins Hospital, specializing in managing, treating patients diagnosed with congenital heart disease and lipid disorders at Johns Hopkins Adult Congenital Heart Disease Center of the Johns Hopkins Heart and Vascular Institute. She's certified clinical lipid specialist. Kathleen's expertise includes cardiovascular disease, high cholesterol, pediatric and adult lipid disorders, congenital heart disease, and cardiovascular disease prevention. She received her MSN from the University of Pennsylvania in Philadelphia, became a fellow of the Preventative Cardiovascular Nurses Association in 2013, and a fellow of the National Lipid Association in 2020. Kathleen, thank you so much for joining us. I know that Saturdays are hard, but we're looking forward to hearing from you talk about homozygous familial hypercholesterolemia and the role of the clinician. Thank you so much.
Great. Well, thank you so much, Brett, and happy to be with you early this afternoon on a Saturday, and thank you for hanging in there today. I'm going to talk about homozygous familial hypercholesterolemia. Oftentimes we'll refer to that as HoFH. We're going to really look at the title is Care with Distinction, Improved Identification, Diagnosis, and Management of Homozygous Familial Hypercholesterolemia, and the role of the clinician. It's me. I do not have any disclosures. And here are our learning objectives. We're going to look at the estimated prevalence versus the number of patients that are diagnosed with familial hypercholesterolemia, and that includes both heterozygous and homozygous FH. Explain the cardinal symptoms and strategies for early identification of HoFH. We're going to discuss recommendations for cascade screening and indications for appropriate referral. And then finally, take a look at the role that the newer low-density lipoprotein receptor independent treatment strategies have in treating HoFH. And they are certainly providing patients with lower LDL cholesterol and therefore better outcomes. Okay, let's see here. We have done hopefully you have done the pretest polling. And we're going to take a basic overview, a look at HoFH. But before we do that, we're going to take a look at familial hypercholesterolemia in general. Familial hypercholesterolemia is an autosomal dominant inherited genetic disorder, and it's characterized by very high levels of LDL cholesterol, atherosclerosis, and a high risk for premature coronary or cardiovascular disease. And that includes not only MI or an acute event, angina, but stroke as well as peripheral vascular disease. It affects all races and all ethnicities. And we do find that there are pockets within certain countries where we have a greater incidence of familial hypercholesterolemia, and that is due to what we call the founder's effect, because these pockets of people of same or similar nationalities group together. And so that would be, we see that in Lebanese Christians, where we see a tenfold increase in heterozygous FH and about 1 out of every 100,000 people with HoFH. We see it in South African Afrikaners. We see it in Ashkenazi Jews. We see it in French Canadians, in folks from Finland, Tunisia, and Denmark. So it's quite a global thing. As well as I want to say that exercise and diet are important, but pharmacotherapy is definitely required to reduce cardiovascular risk. And I will tell you, in the number of years that I have been treating folks with familial hypercholesterolemia, when I see them, because we are a tertiary care center, patients will come in and I will ask them what they do with diet and exercise. And they'll say, oh, you know what? I already talked with my provider. I don't have to worry about diet and exercise because this is all genetic. And that is simply not true. That is foundational for everything. However, if I find that I have a patient with familial hypercholesterolemia, I am not going to wait 3 months or 6 months looking at diet and exercise, but I'm going to start them on medications likely right away. Okay, so now we're going to look at what's the difference between heterozygous versus homozygous familial hypercholesterolemia. And with heterozygous familial hypercholesterolemia, it generally is inherited from one parent, whereas in homozygous, we have both parents are conferring their genetics with two mutations, one mutation from each parent. The LDL cholesterol is elevated, certainly greater than 190 in those who have heterozygous FH, and greater than 400 in patients with homozygous FH. So I will tell you that generally the range for heterozygous FH is between 190 and 450 milligrams per deciliter. And those folks have about a 50% risk of having a cardiovascular event by about 50 years of age in men and by about 65 in women if they are untreated. Whereas folks who have homozygous familial hypercholesterolemia, we said that their LDL cholesterol is greater than 400, generally about 450 to about the highest that I have seen is about 1100 milligrams per deciliter. And the mean age at which patients start to have cardiovascular events would be 12 years old if they are untreated, and death by about the age of 18, again, if untreated. And although patients with heterozygous familial hypercholesterolemia generally achieve significant LDL reduction in response to pharmacotherapeutic agents, those with HoFH have really attenuated LDL lowering response to standard medications. And that's because they don't have significant LDL receptor activity. And so they will require multiple agents. So with heterozygous familial hypercholesterolemia, perhaps the LDL cholesterol can be controlled with one agent, generally more, but with HoFH, multitudes of medications and therapies. The prevalence of this is 1 out of every 250 to 1 out of every 300 individuals with heterozygous FH, and in homozygous, 1 out of every 250,000 to 360,000. And those numbers keep coming down, okay, as we discover more and more individuals who have familial hypercholesterolemia. And I don't want you to think that those numbers that I have given you are written in stone, because we have found individuals who have LDL cholesterol of about 140 who actually have had a positive genetic test for familial hypercholesterolemia. So you really have to take into consideration family history of both hypercholesterolemia, as well as their numbers, as well as the incidence of premature coronary heart disease. Now I want to move a little bit into some unmet needs that we see in homozygous familial hypercholesterolemia. And these are insights that have been gleaned from the Cascade FH registry. And the FH Cascade registry was created in 2013 by the FH Foundation. FH Foundation was Familial Hypercholesterolemia Foundation, which was renamed to the Family Heart Foundation in 2021. And this is a research and patient advocacy organization. And the whole purpose of the Cascade Registry was to describe the characteristics, the treatment patterns, and clinical events that we see in those who are impacted by familial hypercholesterolemia, both those with heterozygous and those with homozygous familial hypercholesterolemia. We have about 40 sites across the country, excuse me, that are participating in the registry. And we have 20 sites that follow those who have homozygous familial hypercholesterolemia. And at the Johns Hopkins Hospital, where I practice, we have both heterozygous and homozygous familial hypercholesterolemia patients within the registry. Okay, so what are some of the unmet needs in diagnosis? Well, first of all, there was a striking result, and that was that we see a significantly higher untreated LDL cholesterol levels in patients who were enrolled in the registry as children as compared to those who have been enrolled as adults. That makes perfectly good sense. The higher your numbers are, it's discovered, and so then we tend to look for treatments, and so they are in the registry. And only the most severely affected individuals, such as those with physical signs like xanthomas, are diagnosed during childhood, where the rest are generally diagnosed during adult years, or they're not diagnosed at all. Well, why do we not? So that let me go back here and say the median age of diagnosis for children is around 2 if they have very high levels. The untreated median LDL cholesterol for children is about 776, whereas in adults it's about 533. And then the onset of atherosclerotic heart disease is earlier in children than in adults. We have seen some unmet needs in treatment in the fact that 68% of adults and 75% of children had not reached their goal lipid levels despite having specialty care and the availability of potent LDL cholesterol lowering agents. And so that means specialty care, folks who specialize in lipid abnormalities. That does not necessarily mean a cardiologist. Cardiologists may identify this, or a pediatrician may identify it, but we're talking about with good solid treatment, it's usually done by a specialist. And we also have found through the registry that adults who have been treated with LDLR independent agents, which we're going to talk about later, such as evinacumab and lamidopide, exhibited LDL reductions that were 50% above and beyond that achieved with other lipid-lowering therapies. So why don't we see patients having the diagnosis, being labeled or being diagnosed with familial hypercholesterolemia and HoFH? Because as children, they may not have the classic HoFH findings. Okay, so they may not have, their bodies may not be covered with xanthomas. Perhaps there's an incomplete family history. And the longer I practice, the more I realize that with families that are spread all across the country and the world, oftentimes family history is unknown. So it is a really important thing to try and learn family history. There's a lack of clinically evident atherosclerotic cardiovascular disease in the parents of children with HoFH. And that's often because they may be younger, as well as the fact they haven't been properly diagnosed. And a number of parents have been treated for hypercholesterolemia without a diagnosis of familial hypercholesterolemia. So I often hear, well, I have a high cholesterol level and I'm taking a statin, so I'm good. Whereas when I delve into things or just look at their LDL cholesterol level and it may be 400, that's a real alarm for the fact that this is likely familial hypercholesterolemia. Okay, let's go on here. Okay, so we do see, I want to point out a couple of things, that only about 71 folks within the registry, or 26%, had a diagnosis code for FH. We've had a diagnosis code for FH now for several years, and it's not put in the medical record as such. It may just be elevated LDL. 84% of the patients were under the age of 50, 20% had ASCVD. Here are some unmet needs in treatment. 40% of those individuals identified as having FH were not on lipid-lowering therapies. Only 19% of individuals were on high-intensity statins, and only 18% were on more advanced lipid-lowering therapies, such as PCSK9 inhibitors and lamidipide. So not only are we not diagnosing it, but we're not clearly treating it. And the first thing we have to do is diagnose it before we can appropriately treat it. Okay, it's estimated in the United States that there are probably about 1,100 to 1,300 individuals who have FH. Okay. All right. Okay, so what about screening and diagnosis? First and foremost, we look for some physical findings of homozygous FH. And we can often see, I'm going to point out cutaneous xanthomas, and these are yellowish, orangish xanthomas that you find in the creases of like the wrist or in between the fingers. In between the toes. You may also find xanthelasmas, which are lipid deposits that they're waxy, yellowish, whitish, orangish on the upper eyelids or in the under the eyelids. And I can't tell you the gentleman that I used to work with who has unfortunately passed away. He's identified several folks in the grocery store looking at the cashier and saying, hey, you know, your eyelids have these waxy lipids on them. And have you had a lipid test? Have you had a cholesterol test? And so he's been able to diagnose that, and they've come back to him and they went to their physician or provider and had a lipid panel, and it was diagnosed. Also, corneal arcus, premature corneal arcus, these are lipid deposits that you can see on the outer surface, on the outer circumference of the eye, the iris, and they are lipid deposits, premature being before the age of 45. And so we definitely see them in older folks in their 80s. You can go throughout a nursing home and see tons of that, but prematurely you don't see that very often. Then if you look down onto tendon xanthomas, you can see on the knuckles of the hands that there are these lipid deposits. And you can often, if you have the patient, sometimes these findings are not quite as dramatic, but if you have them squeeze their hands and so flex and extend and flex and extend, you can see that those cholesterol will pop out from the tendon sheath. And then Achilles tendon xanthomas, which are thickening of the Achilles tendon. Oftentimes they will be big and bulging, and some patients may not have anything, but you ask them, if you start to question, they'll say, oh yeah, I had these big things on my ankles, and they had to be cut off because I couldn't participate in sports, or it was hard for me to walk or run. And if you just get used to, again, like I said, a lot of them are not as dramatic, but if you get used to feeling a person's Achilles tendon, every patient that you examine, this is just good physical assessment, and you'll know what normal is. And then when you find an abnormal, you will clearly know what that is. Okay, what are some of the current guidelines for screening for children and adolescents? Well, the NHLBI expert panel, the AAP, so the American Academy of Pediatrics, and the AHA and ACC multi-society guidelines strongly recommend that any child who has a family history of early cardiovascular disease or familial hypercholesterolemia be screened as early as 2 years of age. Actually, if a patient has FH, okay, their lipid levels are likely elevated within the womb. And so, but at 2 years of age, I mean, we've actually looked at cord blood, and you can see that the lipid levels are certainly higher, but 2 years of age is not too young to test. Otherwise, universal cholesterol screening between the ages of 9 and 11. Why did we pick the ages of 9 and 11? You want to, or not me personally, but why did these societies pick that? And that's because oftentimes this is right before patients start to go into puberty. As they go into puberty, their lipid levels will decrease because they are using cholesterol to make the hormones of adolescence. So let's say you catch someone who's like 13 and they're definitely in puberty, and you may see an LDL cholesterol of about 130, 140. You think, okay, no big deal. We'll change their diet or exercise or whatever. And yet, if you catch them later on, like at 16 or 17, they may be as high as 160, 190, 200. So you want to catch them early before they go into puberty. And then again, once they're in, full-blown adolescence. And then you want to repeat screening between the ages of 17 and 21 years of age. We're doing a better job. I would say anecdotally, we're not doing a great job, but the pediatricians are doing a much better job with initial screening between 9 and 11. And then, of course, if they're honing in on family history, even earlier. But a lot of times they don't do that repeat screening. So that's an important point. And then at the current time, the USP, STF, and the American Academy of Family Physicians have made no recommendations for or against routine screening for lipid disorders in children and adolescents. And that's because we don't usually see, we don't have outcome criteria at this point in time for significant outcome criteria for early cardiovascular disease. Okay, all right. Okay, why aren't we screening? Why aren't we screening? One, medical professionals have sort of a lack of awareness. Like I said, we're doing better. There's some conflicting recommendations, like I told you, from the U.S. Preventative Services Task Force and the AAFP versus the other professional societies. There's an incomplete knowledge of family history, and there is some resistance to screening children for hyperlipidemia. Some parents do not want their children to be screened. And I think so there's just that we need to do more education. And the importance of early diagnosis is because if you delay diagnosis, this is a missed opportunity to start life-saving therapy. And we know the earlier that we start therapies, the better it is. For children, typically with heterozygous familial hypercholesterolemia, we can start therapies at about the age of 8 or 10, depending upon the statin that you're using. And with children who have homozygous familial hypercholesterolemia, we are starting them at 2, 3, 4 years of age. Okay, but again, it must be done with specialized personnel. So what's our homozygous familial hypercholesterolemia diagnosis algorithm? Well, first of all, in order to diagnose it, you have to have a patient that you suspect has HoFH. So what's their LDL cholesterol level? Is there a family history of early heart disease? And I'm going to tell you early heart disease or elevated LDL cholesterol. Do not just get a history on mom, dad, siblings, grandparents. Go back second, third generations if you can. Again, I tell you, I've just already told you that people don't know family history, but oftentimes if you delve and they can provide some of that information. That's very important. Okay. Rule out secondary causes of high LDL. So what kinds of things would that be? Like one of the things that you want to check routinely is if the LDL cholesterol comes back high, even before you send them to see someone else, check their thyroids and make sure that they're not hypothyroid. I can't tell you the number of times that I have been surprised, but get the routine thyroid testing and oh my goodness, TSH is greater than 150. And there you go. Then we correct the hypothyroidism, send them to endocrinology, and next thing you know, their lipids may revert back to normal. So rule that out. Folks who have proteinuria, so renal disease, you may find that their LDL cholesterols are higher as well. If there's cholestasis and liver disease, and also autoimmune diseases like Cushing's and lupus. So rule out those secondary causes of high cholesterol. Then you can diagnose it either clinically or by identification of the biallelic FH variant, so genetic testing. I'm going to tell you that you really do need genetic testing if you are looking at someone who has a higher LDL cholesterol, but you're looking, it may be second generation or third generation back that they have early heart disease. So that's when we would really lean heavily on genetic testing. Now, how do we diagnose this clinically? Oftentimes we use here in the States something called the Dutch lipid score. So we take a look at patients who have higher levels of LDL cholesterol, and we assign them points for certain things, like depending upon what their LDL cholesterol is. So if the LDL cholesterol is 330, they would get 8 points. If a patient has premature coronary disease, they would get 2 points. If a patient has a family member with early heart disease, they would get a point. If they have physical findings such as xanthomas or extensor tender xanthomas, Achilles tendons, they would get points. And so then you add up your points, or they can have genetic testing. Genetic testing, if they're positive with genetic testing, they have 8 points right there. So if a patient has greater than 8 points, they have definite FH. And then if they have less than 3 points, it's unlikely that they may have FH. So you can do this clinically. And then what do you do once you diagnose them? Refer them. HoFH patients should always go to a specialty lipidologist. They need to have patient education, and then we need to do cascade screening of family members to identify other family members who have FH. And then our goal would be, once we diagnose them and refer folks, we're going to try and reduce those LDL levels. Okay, so let's take a look at our first patient. This is a 19-year-old female who at the age of 17 was found to have elevated LDL cholesterol, very high, so 560 milligrams per deciliter. And her HDL cholesterol was kind of borderline low at 40. I would expect a 17-year-old to have an HDL of about 50, particularly female. And there were no prior cardiac events. When you are doing a cardiovascular exam, you listen with your stethoscope and you pick up that there's a very high-pitched crescendo, decrescendo, mid-systolic ejection murmur at the upper left sternal border, radiating throughout the precordium. Okay, and current treatment, she's on a statin. Don't know whether it's a atorvastatin or rosuvastatin, pravastatin, but she's taking a statin. Family history. There's premature cardiovascular disease on both the maternal and paternal side, but this was not reported at her visit when she was 17 and the LDL cholesterol was found to be high. And now when she presents, she says she's having chest discomfort. So here are a couple of audience polling questions for you. Based on the patient's presentation, what would be your next step? Would you repeat the lipid panel, order angiography, so get a cardiac cath or a CTA, order an echocardiogram, or order genetic testing? Okay, So 39% of you said order an echocardiogram. Good answer. 36% said order genetic testing. 12% of you said order angiography, and 15% of you said repeat the lipid panel. So I'm going to tell you, I would probably do all of those, okay? But I would definitely get genetic testing. I would repeat the lipid panel because I just like to be certain of knowing that this is definitely a valid lipid panel. Okay, these were tested before. Let's just do another one. But I would go ahead and start treatment. Perhaps they need a CTA or cardiac cath, but I would get the echo first. Okay, I would probably get the echo before I got other angiography, but definitely all of them are correct. Okay. Why is genetic testing important for individuals with suspected FH? Is it to make the diagnosis? Is it to guide treatment? Is it to improve survival? Great. It is actually all three of them. Instead of just saying to make the diagnosis, perhaps a better response would, or a better answer would be to confirm the diagnosis. Because what if somebody had like a Dutch lipid score of 6? So that's probable, but you want to confirm it, then you can get genetic testing. So it can confirm the diagnosis. Definitely it helps you in guiding treatment and to improve survival. Yes, because if someone has positive genetic testing, okay, and we have plenty of people that have a clinical phenotype of HoFH, but may not have positive genetics. Okay, and so we're going to be aggressive with them. But if I have the diagnosis confirmed with genetics, I'm going to be even more aggressive. Why? Because the literature supports the fact that those who have genetically confirmed FH, be it HE or HoFH, have earlier and more severe presentation of cardiovascular or atherosclerotic cardiovascular disease sooner rather than later, okay? And if we're treating more aggressively, we can certainly improve survival. Okay, so here we go with some rationale for referring patients for genetic testing. Facilitation of the definitive diagnosis, the pathogenic variants indicating higher cardiovascular risk, just what I said before, the potential need for more aggressive lipid-lowering therapies. It can actually help patients to realize this is a very real condition, and it can help them to say, oh yeah, you know what, maybe I do need to start therapy, and then they'll tend to be more adherent. The only time that I find folks are not as adherent would be those years between later adolescence, when they kind of go off on their own, to young adulthood. And oftentimes people fall off the wagon with treatment. And then you can cascade testing of at-risk relatives. So all like siblings and parents and grandparents if necessary, okay? What are the cons? What are the cons with genetic testing? Well, they just may be confused. I don't really think I need it, okay? You know, you've already told me I probably have this clinical diagnosis, so I'm confused now. So why do I need it? It's also a reason to get it is because sometimes patients may not have physical findings, okay, or their LDL cholesterol may not be significantly, they may not be as high as we suspect they should be. And so a lot of the pharmaceuticals require that we document that they have FH before they will authorize a medication. There may be discrimination when it comes to life insurance. So a lot of patients will say, you know what, I just want to hold off with genetic testing until I have life insurance. They cannot be discriminated against for health insurance, but life insurance they may. And then a negative test does not rule out diagnosis, okay? We have about 2,300 variants or mutations, discovering more and more each day. And so someone may come out and they may say, you know, we're not sure if this is a significant variant or not, but once we find that there's more and more testing, we may then find that there are these variants that pop up more and more, and then they're identified as being pathologic. So those are some of the cons. The JAC scientific expert panel recommendations say that genetic testing should be offered for patients with definite or probable FH and for at-risk relatives. And the testing is typically includes genes encoding for LDL receptor, so LDLR, ApoB, ApoE, PCSK9, LDL-RAP1, which is an autosomal recessive hypercholesterolemia, and cytosterolemia. Most of these panels today include these. And we recommend that genetic testing be done in conjunction with a genetic counselor. We're very fortunate that we have that where I work. Okay, so the American Heart Association diagnostic considerations for patients with FH. I think that we've gone over this. I just want to state again that those numbers that we have given you for suspecting FH, be it heterozygous or homozygous, are not set in stone. So oftentimes, if I'm not sure, then I will consider getting genetic testing. Okay, so here we go with our patient, again, making the diagnosis, and she had genetic testing, and it was positive, and DNA testing showed 2 mutations or variants, we call them now, in the LDL receptor gene. Her LDL cholesterol level was greater than 560 milligrams per deciliter, so qualifies her mutations in 2 genes, okay? 2 mutations or 2 variants in the LDL receptor, that is homozygous FH, and her LDL certainly meets the criteria for that. When they did angiography, they looked at the aortic root, and there was atherosclerosis, and we typically see disease of the aortic root and the aortic valve, not uncommon with homozygous FH, and have had plenty of early or young adults, late adolescents who have had to have valve and aortic root replacements. As well as there was 80% stenosis in the mid-LAD and non-critical disease in the right coronary artery. The echocardiogram showed some turbulence at the supravalvular level in the aorta, and there were several calcifications. Very typical findings. So again, let's go to a polling question. Once the patient has been diagnosed, would you recommend that her family be screened? Absolutely. 99% of you said yes. So great. Okay, so cascade screening for familial hypercholesterolemia is certainly very beneficial. It's highly effective. It's recommended by both national and international bodies. It's essential to screen parents, siblings, and children of a person diagnosed with FH to identify others with the gene. So very important to be done. Now, I want to tell you how we typically have approached cascade screening, and something newer that has been identified or proposed by the Family Heart Foundation. Currently, the approach in the United States is there's your provider in green, and there's a conversation between the provider and the patient or the proband, okay? Both of them are physically located in the same state of Texas here. They have a conversation and they suggest that their relatives, that they talk with their relatives about being screened. Oftentimes, provider offices will give them a little letter or talking points to discuss with the family. And then the question is, are all of the relatives of the proband approached? And then here we go. Let's say one is definitely approached, but they're asked to contact their provider, but there's been no follow-up. So a lot of people can be missed even once they've been, the proband has talked with family members. A more centralized approach is that the provider talks with the patient, okay, and says, you know, we have a coordinator from the FH Foundation who is able to talk with you and consent to talk with you about the need for family screening. And this coordinator really supports a conversation between the proband and their relative, and that FH Foundation representative can directly contact the relative if permission is given. And then the relative of the proband is educated and agrees to be screened. I'll just tell you the success of this. Prior to engagement of this centralized approach, about 80% of total families were screened. And after engagement, about 55% of families agreed to participate in cascade screening. So it definitely ups the participation. Okay, so now we have identified it. We've gotten all appropriate individuals screened, hopefully. Now we want to talk about how do we treat this? Early diagnosis and treatment with combination lipid-lowering therapy with at least 3 and frequently more treatments, including lipoprotein apheresis. You may have heard of it as LDL apheresis, is crucial to approach LDL target and prevent the cardiovascular consequences of homozygous familial hypercholesterolemia. So what do the guidelines say? Okay, the guidelines would say that you should lower the LDL cholesterol to less than 70 milligrams per deciliter in primary prevention and less than 55 milligrams in secondary prevention in those with FH. So if you've got a homozygous FH patient and you've looked at their Doppler, they have aortic stenosis, you've taken a look at the angiography and their calcifications, etc., and stenosis there, you know that you want them certainly below, below 55 milligrams per deciliter. And because of disease severity and the response to treatment varies considerably between patients, due at least in part to the degree of residual LDL receptor activity, this necessitates a personalized approach to management of HoFH driven by LDL target levels. What this is really saying is this is not a one-size-fits-all. So we have to individualize our treatment protocols, just like with everything with patients, okay? And so let's say an individual has homozygous FH. They could have 2 variants in the LDL receptor, or they could have a variant in the LDL receptor and ApoB. And I will tell you that typically those who have variants in the ApoB do not tend to have as severe a presentation as those with variants in LDLR. So you can have a little bit of a different presentation clinically. Okay, so what do we do? How do we approach this clinically? We already talked about the fact that we want to do diet and exercise, but we're not going to just say do this for 3 or 6 months. We're going to say, let's start you on the maximally tolerated high intensity statin. So high intensity statins would be atorvastatin and rosuvastatin. Atorvastatin at 40 milligrams or 80 milligrams per 40 or 80 milligrams per day, and rosuvastatin at 20 or to 40, and then up titrate that to their maximally tolerated dose, knowing full well that your biggest bang for your buck is going to be the first dose of the statin that you give them. Okay, so if you think that the patient can tolerate 40 milligrams, do it and see how much LDL lowering you get. Now, the whole statins work by relying on an LDL receptor that's functioning, because the statins will upregulate that LDL receptor. So in some folks who have less than 2% of a receptor, okay, left, let's say that we call them null receptor, you're not going to get much of a response at all, if anything. So you go from, you can do the statin. If their LDL cholesterol is not at goal, you can add on ezetimibe. And then if they're still not at goal, then you add on a PCSK9 inhibitor. PCSK9 inhibitor requires that you have a functional LDL receptor. So you may find that you don't get a real great LDL lowering. Maybe you might only get 10% LDL lowering. If that does not work, okay, discontinue the PCSK9 inhibitor, and then you add on evinacumab, which is one of our newest drugs, okay, and that is administered at 15 milligrams per kilogram IV every 4 weeks. It takes about an hour for an infusion to take place. If the LDL cholesterol is not at goal at that point, then you can add on lamidipine, and we'll talk about that in a second. Or you can, if they're still not at goal, you can then have them do LDL apheresis. So that's the basic setting there. Okay. So standard therapies, already mentioned statins. Okay. And what are some of the limitations? So the drug interactions, but that's pretty not a big deal. LDL receptor dependent mechanism. So you need to have a functional, we at least need some functioning of the LDL receptor. Ezetimibe, okay, again, you need an LDL receptor that's working to some extent. You can see some GI effects. There's only one dose of ezetimibe, and that's 10 milligrams. Or you can use as an add-on bile acid sequestrants. They only reduce LDL cholesterol by about 15%. We used to use these in the good old days. By the good old days, I mean 30 years ago. Okay, it was like eating sand or drinking sand. Problem with this is it can increase triglycerides in folks who already have elevated triglycerides. There's lots of drug interactions, so you have to time when you take your other medications. Do we still use the bile acid sequestrants? Yes, but in select situations. So it's not a common thing. It would only really be an add-on. And what about LDL apheresis? Well, LDL apheresis or lipoprotein apheresis is indicated for those who have familial hypercholesterolemia, both heterozygous and homozygous, an elevated lipoprotein little a, and resistant HeFH. Okay. It's a very valuable treatment, but it is underappreciated and underused. It's an adjunctive therapy. We don't go to it right away, but it's very helpful. So you will walk out, you can walk in with an LDL cholesterol of 300 and walk out with an LDL cholesterol after about a 3-hour treatment. It's kind of an extracorporeal thing. They filter out all the ApoB or atherogenic lipoproteins. And so again, 300, walk out with an LDL cholesterol of 50. But then Immediately when you get discontinued or disconnected from the machine, your LDL cholesterol begins to increase and approaches baseline by the end of about 2 weeks. Okay, there are some individual differences. So you need to have this. This is a reoccurring thing. I will tell you, with a lot of the newer therapies that we have now, we're not using it quite as much. One of the problems is there are only about 60 centers within the United States, so patients really have to travel. Oftentimes today, we're using it in patients when they're pregnant. And so we want them off of all of their lipid-lowering therapies. And so throughout pregnancy, we may put them on LDL apheresis, okay? Not only does it lower the LDL cholesterol and other apolipoprotein B particles, but it decreases pro-inflammatory and pro-thrombotic factors. It decreases blood viscosity. It acutely increases microvascular myocardial perfusion. And so that's why a lot of patients who may be having, let's say, resting chest discomfort, they come in, they have their treatment, and they find that for a period of time, they're chest pain free. And it may provide additional benefits such as pro-endothelial effects. So very good, but accessibility is a problem. It's a quality of life issue if you have to travel 300 miles to get it, if you have to take a day out of your life for this treatment. You know, they will say it only takes about 2 or 3 hours, but you have to go, you have to get hooked up, you have to have the treatment, and then we need to watch you a little bit because there can be some fluid shifts afterwards. But a good therapy. Okay. Here are the newer LDL lowering therapies, and I want to kind of hone in on a couple of them. The PCSK9 inhibitors, and your PCSK9 inhibitor is alirocumab or evolocumab. Okay, they are subcutaneous injections. They are dependent upon an LDL receptor. They will result in an LDL lowering of about, if it's heterozygous familial hypercholesterolemia, about 50 or 60%, but with homozygous may only be maybe 20%, or if they're, like I said, no receptor, less than 2% of normal receptors, then maybe nothing, maybe 5%, 10% LDL lowering. Okay, the cost is maybe cost prohibitive, although it's been available now for us since 2015, and the prices have really come down. There's lots of grants that we can get. The pharmaceutical companies have helped us a great deal. Okay, and we can give this to folks who are 10 and above. Okay, lamidipide is what we call an MTTP inhibitor, or a microsomal triglyceride transfer protein inhibitor. What does this do? It reduces the hepatic production and secretion of VLDL lipoproteins, so very low density lipoproteins. And that VLDL cholesterol is a precursor to LDL cholesterol. So if you lower that, okay, then you won't have as much LDL cholesterol being made, and it's not dependent upon an LDL receptor, okay? And if it is, when it's used and added to standard therapies, you can see a reduction in the LDL cholesterol of about 50%. Problem is that there can be some very adverse GI effects and hepatotoxicity. Patients need to be on a very low fat diet. And it's approved for patients with HoFH who are 18 or above. I have used it in the past with my HoFH patients. The problem is that try and get a teenager not to have pizza. Okay, and that's a huge problem. Okay, or try and, you're like, we don't want you to have alcohol, and that's a problem. Not just reduce it, but you really need to eliminate it. And then they need to get like monthly liver function tests, so that it works very well. It was a drug that perhaps was a little bit ahead of its time, but you have to be highly motivated to use it. And then we have evinacumab. Okay, it functions by an LDL receptor independent mechanism, and you can reduce LDL cholesterol about 47% from baseline when it's added on to standard therapy. We don't eliminate other therapies, but it's an add-on, okay? And these folks have, folks who have less than 2% LDL receptor function have achieved LDL reductions of about 72% versus placebo. It's an IV infusion. It's given once monthly, but again, it's very costly. And I'll go in and show you this. So this evinacumab is an ANCC inhibitor. Okay, this is ANGPTL3 is protein. Okay, and during normal homeostasis, this ANGPTL3 or angiopoietin-like 3 protein diminishes the activity of the vascular lipases, both LPL or lipoprotein lipase and EL or endothelial lipase, okay? And therefore, they help to regulate ApoB containing lipoprotein turnover. So if we have evinacumab, which is an ANGPTL3 inhibitor, what it will do is it reduces the formation of the LDL cholesterol by promoting clearance, again, of VLDL, the very low density lipoprotein, through endothelial lipase dependent pathways. Okay, so it unblocks, another way of saying this, is it unblocks the inhibitory effect of ANGPTL3 on both lipoprotein lipase and endothelial lipase. And then you don't have, and then you have significant LDL cholesterol lowering. Okay, so very, very new, and patients are doing very well on it. What kinds of side effects do we see when patients get it? You can see that they may have cold or flu-like symptoms, and that's because it's a monoclonal antibody. They may be a little dizzy, they may have some nausea, they may have lack of energy. Some patients have no side effects. I have a 15-year-old who's been taking it now for about a year, and she has no side effects, none whatsoever, okay? Now, it may cause fetal harm, so we're not using it during pregnancy. We don't know the effects during lactation, so not using it. And we make sure that patients have effective contraception during treatment and at least 5 months following the last dose of evinacumab if they should come off. The drug is approved for those starting at the age of 5. And we can just, this is a little graph that just shows you the efficacy of evinacumab in patients with HoFH on maximum doses of lipid-lowering therapy. So in the gray, you have placebo, so they're on their regular lipid-lowering therapies, be it a statin, ezetimibe, PCSK9 inhibitor, and then evinacumab is added. And you can see the definite change in baseline, okay? A 47% change or 47.1% reduction, okay, in the LDL cholesterol levels. Same thing, absolute and percent change. So you can see that it really works well. And same thing, you can see LDL receptor independent lowering via the lomidopide. And so again, long-term safety is the fact that we need to take a look at liver enzymes and GI side effects. But again, really good results. This just takes a look at the use of evolocumab, alirocumab, the two PCSK9 inhibitors, or evinacumab on LDL cholesterol levels by mutation status. So what it's showing you is if you have some receptors, some working LDL receptors, you're going to have some response from your PCSK9 inhibitors, the evolocumab and the alirocumab. Whereas if you don't have your null receptor, evinacumab will also lower. Okay, you're not dependent upon that. So very promising, very promising. Okay, so in summary, HoFH remains unrecognized and therefore underdiagnosed and therefore undertreated in the US. We're not screening as much, so we really need to be able to identify, recognize early symptoms, diagnose early, refer for genetic testing, and intervene early. So that will include effective LDL cholesterol lowering therapies to reduce cardiovascular risk. The only way you're going to reduce cardiovascular risk is to lower the LDL cholesterol. Cascade screening following diagnostic confirmation is extremely important to promote early diagnosis and intervention for family members with the disease. And many patients with HoFH fail to achieve their LDL targets despite appropriate therapy, often due to low or absent LDL receptor activity. And that's where, with the advent of these new LDLR independent therapies, more patients with HoFH will be able to achieve LDL goals and potentially alter the trajectory of their disease and significantly improve their cardiovascular health outcomes. So again, I'm old enough to tell you that when I started with this, one of the first patients that I ever saw in conjunction with my mentor, Dr. Peter Kwitovich, sat down and said to the mom, the little girl was 3 years of age, and said, you know what, we're going to do our very best. You need to trust the medical system. I believe that we are going to have therapies in the future, but right now I can't tell you if your little girl will live to be a teenager and an adult. And I can tell you right now that that little girl is a very young woman who now has a baby who has turned 1 year of age. Her baby has heterozygous familial hypercholesterolemia, and she is still thriving and has no evidence of cardiovascular disease. Why? Because she has been treated, for the most part, on a regular basis since the age of 3 years of age. So there is definitely hope on the horizon for folks with HoFH. Okay, on to our post-test polling questions. According to recent estimates, what's the prevalence of HoFH in the United States? Is it between 1 out of every 250 to 300 individuals, between 1 out of every 250,000 to 1 out of every 400,000 individuals, or between 1 out of every 450,000 to 1 out of every 600,000? Very good, very good. The answer is between 1 out of every 250,000 to 1 out of every 400,000 individuals. When I started in this business, 1 out of every 1 million individuals we thought had homozygous familial hypercholesterolemia. So the more we are looking for it and identifying it, the more we're going to find it. Next question. Which of the following is consistent with the current NHLBI, AAP, and AHA-ACC multi-society guideline recommendations for screening in pediatric patients? Universal lipid screening of all children greater than 2 or greater years of age. The second is selective lipid screening of children 2 or older with a family history of cardiovascular disease or hyperlipidemia. And thirdly, selective lipid screening of children 12 or older with a family history of cardiovascular disease or hyperlipidemia. Great. Great, very good. The second answer, selective screening of children 2 or older with a family history of cardiovascular disease or dyslipidemia. Okay. And our next question. In which of the following patients would a referral for genetic testing be required to confirm the diagnosis of HoFH instead of a clinical diagnosis or the Dutch lipid panel? And be careful with this one. Patient with an LDL cholesterol 400 or greater with a parent with clinically diagnosed FH, a patient with LDL cholesterol greater than 400 with xanthomas less than the age of 20, or a patient with an LDL cholesterol 500 or greater with a second-degree relative with premature coronary disease. Okay, so the answer is, and this one kind of everybody gets hung up on, this is a little harder, with the patient who has an LDL cholesterol of 500 with a second-degree relative. So that's the, I made a point of that. It's with the second-degree relative, we really need to do the confirmatory genetic testing, okay? Right. Highest LDL cholesterol levels occur in patients with which of the following? Patients with virtually absent or impaired LDL receptor activity, patients with limited binding of LDL cholesterol to LDL receptor due to a dysfunctional ApoB, or patients with accelerated degradation of LDL receptor due to increased PCSK9 activity. Okay, and the correct answer is patients with virtually absent or impaired LDL receptor activity. That absent activity would be a null receptor, less than 2%. Okay, but good job. Let me see, do I have anything else? No. Okay, I guess we're ready for some questions and answers.
This was so great, Kathleen. Thank you so much.
You're welcome.
Such great information. All right, let's jump to question and answer. Discussing plasmapheresis, do you foresee in the future an opportunity that this plasmapheresis can actually be like a home care service?
Okay, so I'm going to stop you right there, and it's not it's not plasmapheresis, because with plasmapheresis you're removing a lot more particles. Okay, different particles. It's lipoprotein apheresis.
Apheresis.
That would be just the atherogenic lipid particles like LDL cholesterol and LP(a). And do I foresee that it will be a home? That's a great question. Do I foresee that it will be a home therapy? And I would say no, not in the foreseeable future. Quite frankly, what I see is that we're probably going to be, with the newer and newer therapies that are being developed, we're probably going to have very few reasons to continue on with it. Okay. Very expensive. And you can also have, you can have a lot of hypotension that happens.
A lot of side effects to it.
Mm-hmm.
Okay. Will being on a statin affect results of the FH genetic test result?
Great question. The answer is no. Does not impact it at all.
Perfect. This is a longer question. It said, you mentioned the first dose of statin is most effective. I am thinking you're referring to the rule of 6. If we hold the statin briefly and resume at higher adequate therapeutic dose, will this reset the rule of 6?
No, it really doesn't. I wish it did, but the answer is no. So
Cheating the
and that
system.
rule of
Cheating the
yeah,
system.
yeah, the rule of 6 means that in general, not in patients with HoFH, but the rule of 6, for those of you who may not know this, is that you want to give the first dose to try and get an LDL cholesterol lowering of 50%. And then after that, it's generally no more than about 6% LDL lowering. So if you're considering in someone, let's say you have them on 20 milligrams of atorvastatin, and you're like, oh, do I go up to 40 milligrams or do I add ezetimibe? Okay. And the answer would be no, add ezetimibe, because I'm going to get about a 20% additional LDL lowering. Whereas if I just double the atorvastatin to 40, I'm only going to get a 6% additional LDL lowering. So look at how low you want to go.
Perfect. Okay. For the female who has FH, what are the guidelines then for treatment when she wants to become pregnant?
So they're changing a little bit, but typically what we say is to stop using a statin about 3 months prior to trying to conceive. Now, we've got a lot of whoops that have been going on for many years, okay? And that's generally not a problem. So you just kind of stop as soon as, if you haven't, stop when you know that you're pregnant. And that would include the only drugs that would really be approved would be like a bile acid sequestrant, like cholecalciferol, okay? That would be it. So ezetimibe can't be done. We're not sure about PCSK9 inhibitors. There's a registry with that. Now, things are changing, and if you deem, the provider deems that the risk of not being on a statin is higher than the risk of some deformity, okay, in the fetus, then we are using pravastatin, and that's based upon some studies that have been done in patients, I believe, who have had preeclampsia, okay?
Oh, good to know. Okay.
But
And
that's a moderate intensity statin, and you're not really going to get a lot of lowering.
Not a very big bang for your buck.
No.
Someone's asking about Dutch scoring information. I assume you could Google that, but where's a good place to find that?
Just look up Dutch lipid scoring, okay? And that will tell you, that will walk you through the steps as to how to score someone. So Dutch lipid scoring.
Okay, perfect. Talking about cascade testing, is there documentation that's required for initiating cascade testing? I assume to get it paid for, like what documentation needs to be used?
So yeah, you need to, you would certainly document within your notes what the LDL cholesterol is and the family history is, okay? And that would be, and then in order to get cascade screening or get genetic testing, you would then, we recommend that you go through, that the insurance company pre-approves it first.
Of course, yeah.
But the testing for that, I'm sorry to interrupt you.
That's okay.
It used to be very cost prohibitive. Now you can generally get it done for about $200 if they're charging something. And a lot of the genetic counselors work with the companies that do the actual testing, and oftentimes they will waive or reduce the price. So it's worth working with a genetic counselor.
Do you see it covered by insurance?
Yes.
Okay.
Yes.
Okay.
There are
so this is just in the event that
but there are insurances that do not.
Of course. Yeah. And then 2 more questions. One, for a known parent with HoFH, does the child need testing, or do we treat as HeFH? Sorry.
No, I would get testing.
Testing, I would think.
I would get testing, yes.
Okay. Should we be doing more than just a routine lipid panel? And I assume this is, they're asking with all patients, such as ApoB or LPA.
Okay.
And if so, how often?
Yeah, okay. So let me tell you about ApoB apolipoprotein B is probably, if you ascribe to this theory, which I do, okay, is probably a more accurate representation of the amount of atherogenic particles as opposed to the LDL cholesterol. I would not get an ApoB until you have normalized, if your patient has higher triglycerides, until you've normalized them as much as you can. And then you can repeat that with therapy. You know, you can repeat that as you change your therapies or refine your therapies, then you can do that. Now, once you've gotten an ApoB, I will also tell you, then you can use what we call the poor man's ApoB, which is a non-HDL cholesterol. So your total cholesterol minus your HDL. So if you already have an ApoB and you know what your non-HDL cholesterol is, then you can kind of use that as a guide to what your ApoB would be in the future. Okay, but it's not that expensive. It's about $35 for a draw. Now, with a lipoprotein little a, that is basically a one and done test. Okay, it is definitely genetically 99% of the time genetically determined. Okay, and so if an individual has an adult level of LP little a by the time they're 5. So if you have a child and you've tested and they're like 2 or 3, and you've tested their LP little a because their parent has had premature cardiovascular disease and found to have an LP little a that's elevated, then you check it if it's high or borderline high, then repeat it after the age of 5 once. Otherwise, for the most part, you do not need to have it done. Again, one of the exceptions that we're finding is after menopause. Women tend to have, if they've had a little bit of, if they've kind of been on the borderline of having an high LP little a, we do find that it elevates.
Estrogen is a magic thing.
Yeah, it really is.
So protective.
Yeah.
All right. Well, that's all the questions. And thank you so much again, Kathleen. Such a wealth of knowledge. You're just such an expert in this.
Oh, well, thank you. Anybody who has any questions, feel free to contact me. We're happy to help.
Absolutely. Well, thank you everybody for spending your Saturday morning with us and early afternoon. And on behalf of Integrity Continuing Education, thank you again. Just thank you. If you have questions, email them to us and they will get them to the speakers. Also, don't forget to watch your email for evaluations. They will be coming to you for you to evaluate our presentation. And if there is no further things to do, then I will give you the rest of your afternoon back. Thank you so much. And thank you for joining us. Have a great day.